reflexes.
Okay, I think, oh God, that is horrific. There is not much we can do about that now. Welcome everyone. Let me put this on. We are so well prepared for today. I love it. So,
Definitely weren't fixing everything literally 5 minutes ago.
yeah. Let me just make sure that works. Yeah, that works great. Fantastic. So, welcome everyone to CompSoc Week 8. Before anything else, I just wanted to give a massive thank you to everyone who attended LANHack this past weekend. This was our first hackathon, as far as we're concerned, at Lancaster University, and we're very, very proud of everyone who took part, everyone who made some cool things, as well as everyone who volunteered there. So if you're a volunteer who helped out at LANHack, thank you so, so much. I'm gutted that I wasn't able to be there, but I am very grateful for your support. And well done to everyone who won as well. I don't think we have the winning team here tonight, but I do know we've got some of the hackiest hack people here, so well done with that. And yeah, thanks for making it a success. Fingers crossed we can have another one in the near future, and it can be even bigger and better. So tonight, welcome to Week 8. Today we're doing, we're doing machine learning for image recognition, and it's going to be a very special evening. I'm so thankful for all of you for being here, especially as you could be anywhere else. I'd like to thank everybody helping out with us tonight. So we will be hearing from the Lancaster University Radiology Society, who have been in contact with IRJ. They are the British Society of Interventional Radiology with the IR Juniors program, who help out with radiologists in training throughout the UK. We have Lancaster University Neurology and Neuroscience Society. We've got LU MedTech. We've got Femtech. We've got Google Developer Students Club, who is also sponsoring us and providing the snacks for afterwards. There will be refreshments afterwards. And of course, to all of you coming here tonight, thank you, everybody. So, with all of that out of the way, obviously, there is going to be quite a bit going on tonight. This is what we can expect. We will start by listening to, I didn't remove one of the names. We'll just be listening to Monda Laffy from the Radiology Society. He's going to show us how to analyze an X-ray like a radiologist, following which I will join in and I will introduce you guys to convolutional neural networks for image recognition. We will be doing this on X-rays, sticking with the medical theme, after which both Roxana and Robbie will be teaching us how to analyze MRI scans like a neuroscientist. I will conclude with a demonstration of somebody else's CNN that I stole on the internet, giving credit where it's due, of course, before we can all have some snacks, have some drinks, and make some friendships that we otherwise wouldn't have. So without further ado, as always, you will not know everything by the end of tonight. This is such a wide variety of topics, some of which you've never seen before, I've never seen before. You're not going to know everything, and that's completely okay. You are still going to learn a lot, and we encourage you to just try along. Even if you don't understand everything at first, we are recording this session and it will be uploaded to the, actually no, we're live streaming, sorry. We're live streaming this session to the CompSoc YouTube channel. If there's something you'd like to catch up another time, feel free to check out the video and replay any certain points you liked. Also, the slides and the code will be made available later on. So without anything else, we will get started with LU RadSoc. Hearing from Monda Laffy. Monda is a 5th year at Lancaster University and is studying medicine. He is also the president of the Radiology Society and the events officer for the Neuroscience Society. Everybody please welcome Monda.
Just make sure my There we go. So like Andre said, I'm Monda Laffy. I'm one of the final year medical students here at Lancaster. I'm also the president of the Lancaster Radiology Society as well, so we're kind of a new society and this is one of our first events, so really looking forward to kind of just showing you guys what radiology is all about and just starting you with the basics. I know there's a lot of people here, majority of you are computer scientists and don't have much exposure to medicine and the basics of radiology, but I know there's quite a few medics here as well. So basically just setting off the objectives really, I just want to kind of create an awareness of what a chest x-ray is and what we radiologists kind of do as a day-to-day basis. I've spent a bit of time with radiologists throughout my med school career, so hopefully I've got a bit of an idea of what to kind of tell you guys about. But for the medics, it's about interpreting. Throughout medical school, I didn't get much teaching at all about radiology, so hopefully this kind of gives you a bit of exposure. I know a few guys are sitting their finals this year, so just in terms of the exams, just understanding the basics, and hopefully we can get through that. So, Andre's not mentioned, but since you are in this room, you are all doctors officially, so for the next hour or so. So I need you guys to be engaged with me and trying to figure out what's wrong with these patients. So if you guys are not aware, this is a chest x-ray. Anyone got any idea of what's wrong with this patient? I'm not going to give you any background. Yeah, no. No, not collapsed lung.
Is it a normal chest x-ray?
It's a normal chest x-ray. I thought it'd be a bit mean to give you a collapsed lung as the first chest x-ray you've ever seen, so this is a normal lung, and it's important for all medics to understand what normal is, what normal anatomy is. Without knowing that, it's very difficult to be aware of what the abnormal is. And that's, in fact, our whole first year of medical school is understanding the anatomy and understanding what normal is. Just so when we see the abnormalities when we're in placement, we can kind of recognize, yeah, that's a bit weird. Maybe we should investigate this. So yeah, this is a normal chest x-ray. And these are everyone's guide, really, to become a radiologist. And hopefully by the end of today, everyone can kind of look at the chest x-ray and say, what can I do to kind of figure out what's going on? And just have an idea what they're looking at, really, because obviously it is quite difficult. So, like I said, understanding the anatomy, that's the first step. Next is something that we do throughout medicine, is a systematic approach. There's so much in the field of medicine, and not having that approach makes it very difficult. There's so much to know. If you do it kind of just spontaneously, you can miss a lot of things. So, like everything, there's an approach to it. It's kind of a universal one. There's a few differences in the acronyms and mnemonics and things like that, but hopefully the one we discuss is kind of the thing you'll see most commonly. And yeah, experience, and then that will kind of give you that ability to recognize patterns. And obviously, I know not everyone here is going to be a doctor, but I think that comes in all walks of life, that experience will kind of give you that understanding of what things to kind of connect with and what patterns you can see. Comparisons kind of coming into the systemic approach. So I'm talking about comparing with previous x-rays. Most patients you'll see with an x-ray will be in their 60s with a previous chest x-ray they've done. You can have a chest x-ray for all sorts of reasons, so chances are there's one they've previously done which could be normal. So comparing with those is always important. It's one of the first things that we kind of say as doctors that we want to do is a lot of them have multi-screen, multiple monitors, have one on one screen and one on the other, so you can compare. Because everyone's anatomy is different. So knowing a normal for everyone's good, but knowing a normal for an individual is also very important. And collaboration. So like we're doing today, we're collabing between computer science students, medical students, med tech, all sorts of people. So especially in medicine, a radiologist is going to be collabing with a cardiologist, a respiratory doctor, a surgeon, a lot of people. So what they see in a chest x-ray might not present clinically. So understanding that this might be abnormal for this patient, but it could be normal for their whole life. So that's also important. That's important in collaboration. And this, obviously, a lot of you guys might not have done biology in GCSE or A-level, so I just wanted to go over the basics, really. So on the left image, it kind of shows you can obviously see a heart on a chest x-ray, even though the lungs are in front of them. But it shows you the basic anatomy, so the blood vessels there, the vena cava that drains into the right atrium, and so you have 4 chambers, as you might know already. So you have 2 atrium and 2 ventricles, and you can kind of see them on this right side. Obviously, it's all black and white, which kind of comes into the point of what do the colours mean. So can anyone tell me what white would represent on a chest x-ray? So if I point to that, this, Yes. Yeah. So bone, yeah. So anything high density is bone. So I've kind of maybe should have mentioned this already, but in terms of the X-ray, it's electrical magnetic radiation that's kind of transmitted through the body, and on the other side is a monitor that can kind of detect how much X-ray has gone through, and that represents the density, and that's what you see. So it's a 2D modality. Obviously, we're 3D, so it's not the perfect, it's not the most accurate, but it's the cheapest and the best thing we can do on an average scan. So obviously, these are our lung fields. Black is the air, and any grey is either going to be is mostly going to be fluid. So here, they're mostly blood vessels. Here is your stomach. So you can see the little bubble in the stomach there. This part will represent the diaphragm. And yeah, these are lung fields. Obviously, your clavicles there, your spine there. So understanding these basics will kind of help you go into interpreting the scan. And this is our systematic approach. So the first thing you want to do before we do anything is make sure we've got the right patients. In the world of medicine, a mistake can be quite costly. You diagnosing a condition on the wrong patient or treating the wrong patient could cost you a lot of money and can be sued. And it is kind of a costly situation if you ever make that mistake. So when a doctor ever approaches you and says, what is wrong with this chest X-ray, make sure you've identified the patient's name, the date of birth, age, and sex as well. And like we said, comparison, so compare with the previous. We'll do that first of all. We'll have that on 2 screens. And then we'll start with the interpretant. So rotation. So in terms of a chest X-ray, you'd normally assume you'd be stood up, but for all sorts of reasons, someone might not be able to stand up. So identifying the rotation is really important. So they could be stood up, they could be lying down, they could be in all sorts of positions. So identifying that is really important because it could change the way you interpret the scan. Does anyone have any idea on how we assess if a rotation's good, that we can adequately interpret the scan? It is kind of a technical thing. So we look at the clavicles. So these are our clavicles here. We make sure the vertebrae in our spine is exactly center between our clavicles. So obviously, a lot of you guys might be seeing this for the first time, so it might be quite faint, but these are our clavicles here, and these are our vertebrae. If this is kind of aligned directly in the middle, we can kind of say in our report that the rotation's adequate and it's good. In terms of the inspiration, that's to do with how well filled the lungs are. So we want our lungs to be as filled as possible, really, to make sure we're identifying all the structures, and if there's any abnormalities there, that we can identify it well. And usually count that by the number of ribs. So here, these are kind of our posterior ribs. We want to count our anterior ribs. So anterior mean in front, so the rib that are coming round the front, they're more accurate. So more than 5 or 6 counted there will be an adequately filled lung. So this has got 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9's about right. Any more than 9 or 10, you can say that the lungs are hyperinflated. That could point towards more lung diseases. So smoker's lung, COPD, and things like that could have a hyperinflated lung. So projection. Any of the medics in the room know what type of projection you can get in a chest X-ray? No? So you've got AP and PA, so anterior, posterior, posterior, anterior. So the chest X-rays can be shining through your chest anteriorly, so in front of, and detected from behind, or coming from behind in front. This will be important later on. So that's your projection. And exposure is just how well you can see it, how well the exposure is. And typically, if you can see our vertebrae quite clearly, like we can here, that's usually a well-exposed chest X-ray. And then we kind of go into our proper interpretation, so our A, B, C, D, E. So the first thing we'll do is check our airway, and then make sure in our trachea here is center. There's all sorts of conditions can kind of pull our trachea one way or the other. I won't go into the details of that, but it's just important to make sure the trachea is straight. And breathing. So obviously this is a 2D modality, so it's tricky to describe. So the lungs have lobes, and that's kind of like it's difficult to describe those in 2D, so we kind of call them in zones to make it very easy. So we just kind of go upper, middle, and lower zone, and we just kind of go that systematically, go in upper zones, down to the middle zones and lower zones, and we just describe if it's normal or if there's any abnormalities you can see there. And then we just talk about the bones, so you can see all sorts of fractures in here. All fractures can be missed on a chest x-ray, so making sure you're going through them. Each rib fractures can be seen quite well on chest x-rays. Not very well, but it's possible to see them. And in cardiac, just making sure you're looking at the heart. We'll go through that in more detail later on. And then the diaphragm is the thing that obviously sits below our lungs that kind of help us breathe. We can't really see that as a muscle particularly, but you can look at these angles here, which are quite important. So if you can see, these are quite sharp. If they're ever blunted in a way, they can kind of show there might be fluid there, and that can point to all sorts of pathologies as well. And then everything else, just making sure you're looking at, obviously covering the bones and anything in the stomach area as well. So that's kind of the basics of how we interpret it, and this has been to all levels of medics, and this is kind of a system I used in my medical finals, so it's good that you guys are aware of it as well. Have you got a question? Why is it important? Because obviously, if these things can go misdiagnosed, so some patient can be describing chest pains for a long time, they're not aware of the cause, they've checked for all sorts of heart attacks and cardiac arrest and things like that, and that's not been shown, but if you see a rib fracture, that could explain a few symptoms. So this is an example of, obviously the other ones seemed a lot better and a lot nicer to look at. This is a patient that's obviously probably on their side. The x-ray's not got a good exposure, and there's all sorts of pathologies there that you want to see accurately and clearly, and if it's not done properly, it makes it a lot harder for the radiologist to report on it and kind of give the best accurate description of what's going on. So now, I've shown you what's normal. It's time to see a few patients that have come to you and wanting some help really, and as a radiologist, you've got to report these scans to help the other doctors in the room as well. So John is a 22-year-old, comes into A&E with severe sharp chest pain and shortness of breath. And this is his chest x-ray. And I can show you this one's not normal. So there is some things wrong here. And for this one, just as a clue that we talk about the colours, so what black represents, what grey represents, what white represents. And obviously you can compare, obviously we've not got a previous x-ray to compare to, but you can compare lung fields, which can help as well. So does anyone have any idea what might be wrong or what you can see? Not in terms of diagnosis, but what might be wrong?
On the left side, I guess the patient's right side, there's a slightly lighter grey within the chest cavity that
Yeah.
could be the lungs, maybe it's not fully inflating.
You're pretty spot on there really. So this is the lung field, and like I said before, black is air. So you've got a load of air outside the lung field. So this is kind of your lung tissue really. You've got a big bit of air around. So part of the anatomy I didn't describe is, so you've got your lung, you've got an extra lining outside called your pleura. And what can happen is, so that's got all sorts of lubricants to help the lungs kind of stay lubricant and kind of expand well as well. But when there's ever a trauma or there's a hole put into that lining, air can go straight through. And this is what we call, so this is the structure I'm talking about. So you've got this lung field here, and then you've got this extra part here, which is your pleura. And this is kind of like a space. And when there's trauma there or there's a hole there, air can go straight in. And this is kind of a collapsed lung, really. And this is called a pneumothorax. So what this patient's probably presenting with is something called pleurisy or pleuritic chest pain. So whenever they're breathing, they're getting that sharp chest pain because they're not able to expand their lungs. And you get all sorts of types of pneumothorax. You get attention pneumothorax. So attention pneumothorax is when kind of air goes in but can't come out. So it's like a kind of a closed loop, really. And that's one of the things that can tug away at the trachea and kind of bring it towards. That's why we're kind of making sure we look at the trachea, making sure it's straight. And this is kind of the basics, really. So like we said, pneumothorax is the air collection in the pleural space, collapse of the lung, and it's a life-threatening condition. And what you can see on the right side is two ways we can kind of manage this. It's quite complex in terms of which one we use, but the top one's like a needle aspiration. It's literally, you can use a cannula, so that the things that go in your arm, you can put that in where the air is and kind of aspirate the air and the air comes out. You can kind of hear that. But if the pneumothorax is a bit more severe, or there's more risk towards the patient, we can kind of use a chest drain. So it's literally a tube that goes into kind of this bucket of water, and the idea is the air will come out and bubble in the water, and that's how you kind of relieve the pain and remove the air around the lung. And if the investigations is what we saw really, a chest x-ray or a CT can be a bit better to identify. And the two managers are there on the right. And then in terms of the other things you want to advise the patient is if they're smoking, don't smoke really. I think smoking cessation's a big thing in medicine that we're taught, and there's not like a good amount to smoke. Zero's the best thing to do. And a lot of the discharge advice is about just reducing the risk of this happening again. If you have one, you're at more risk of getting others. So we advise no flying for the next 2 weeks if it's a successful chest drain, and never to scuba dive again, because those pressures and things like that can cause pneumothorax to happen again, really. All right, so you've saved your first patient, but Steve comes in now into your GP. He's a 55-year-old with increased fatigue, shortness of breath, and you've been treating for blood pressure for several years. And this is his chest x-ray. Again, this is not a normal chest x-ray. There is something wrong. So rather than giving me a diagnosis, just trying to point out things that you think, that looks a bit weird, this doesn't look normal. Anyone got any ideas?
They've got a pacemaker.
They've got a pacemaker, that's a very important thing to identify, yeah. So this here is our pacemaker, and it's got kind of two leads that go into the heart.
They've got a big white mass in their right.
You mean here, or?
Yeah, like it's taking a lot more space than the normal one.
Yeah. So what's there usually? So what's here normally? Okay. Does it kind of look like it's coming from the same area? Not as such. So it is the heart. The whole thing is the heart. So this guy's got a very big heart. So years of being treated for blood pressure or medications that he's probably not been taking has kind of led to this point where he's a bit worried, he's a bit short of breath, and in fact he's got a very big heart. So we've got a big organ, we call it megaly. So it's cardiomegaly, that's what that interpretation would be. And in terms of how we kind of say if the heart looks big or looks small, we kind of use this ratio, so we kind of measure along the heart size and then the whole chest size really, and we divide them, and if it's higher than 0.5, we can kind of say it's cardiomegaly, it's a big heart. So this one here, he had a 0.66. So what was the first thing, what do you think the most common cause of a bigger heart would be? Smoking could cause the thing that's number one. So it could be a precipitant for the thing that's number one. We've already mentioned it. What was that, sorry? Hypertrophy. So hypertrophy is kind of, could be, so hypertrophy means larger. So that could be just the heart size being larger. So high blood pressure is number one, yeah. So 70%, around 70% of enlarged hearts are caused by blood pressure. So the blood pressure is just causing more strain in the heart. The heart's going to work harder, and like any muscle, the harder you make it work, the bigger it will get. And then 2 is coronary heart disease as well. And cardiomyopathy, so when there's ever a pathology in the heart muscles, that can cause your heart to be bigger as well. And so the things that allow blood into the chambers of valves and any diseases of those valves can make the heart work harder to kind of compensate for those issues. So our final patient, so our third and final patient, so you've saved 2 now. You've got a third patient, Mary, a 35-year-old, comes into A&E, and she's got a nasty cough. She's short of breath again, and her temperature's really high, and this is a chest x-ray. So without mentioning a diagnosis, you just kind of describe to me what you see, what's wrong. Any ideas? Where about? Which side? So these diagrams can kind of tell you which side. So this is the patient's left side. So is it left or right? Right. So round here, you'd say? Yeah, that's right. So that is a bit of cloudiness. So that's kind of a grayish color. And what we describe as consolidation. Consolidation literally means just fluid in the lung spaces. So in this patient, so it's important to take it clinically as well. So the patient's got a nasty cough, short of breath, and it's got a high temperature. It sounds like an infection picture. You're going to say something? It is pneumonia, yeah. So in terms of how we describe it, is literally consolidation. Like we said, we call it in zone. So it'd be like the right lower and maybe a little bit in the middle zone as well. So especially pneumonia, you want to describe where the infection is. So it would be like a right lower zone pneumonia. And like we said before, consolidation is just kind of filling of the air spaces. That can be fluid, pus, blood. In this situation, it's likely to be pus because it's an infection. And this is basically the overview. So pneumonia is literally just the inflammation of the parenchyma, the lung tissue, the active lung tissue, most commonly in over 70s, and they're the main symptoms. So you can get that nasty coloured sputum, short of breath, chest pain, and fever. And the most common cause of organism is bacteria. And I'm not sure, yeah, the management is cut off on that as well. So any idea how we treat pneumonia normally? So a patient comes in with pneumonia, what are you going to give them? What was that? Yeah, CompSoc, so an antibiotic. So it's a 5-day course of antibiotics. Obviously, all sorts of organisms can cause pneumonia, but amoxiclav is the most common cause. And we kind of have two main types of pneumonia, so community-acquired pneumonias. So pneumonia you get from here, around the community, or in the hospital, because there's other organisms that live in the hospitals that can cause pneumonia as well, and they might need different antibiotics as well. So you've saved just 3 patients there, and that's kind of my end of my talk, and thank you very much for interacting with my session today, so thank you.
Thank you so much for that. You're right, I did forget to mention that at the beginning. Just for tonight and one night only, everybody in this room is a doctor. So congratulations for that. And thank you also, Monda, for that presentation. That was very, very insightful. And I don't know about anyone else, but I definitely learned a lot. So thank you so much. Now it comes to me. So just a reminder of who I am. So, or if this is the first time you're seeing me, hello, my name is Andre. I am a second-year computer scientist. I used to be an accountant, and I still kind of am. So this time, I'm the treasurer for the Computer Science Society, as well as the Scuba Divers Society. So I know that if I get any of the things you just mentioned, I'll have to give up my scuba diving, so thanks. I'm also the Google Developer Students Club lead for Lancaster University, and I speak with them to help us have fun stuff like this. I will give a quick heads up. Like I said, I'm only a second-year student. I am not an expert. I have had my slides fact-checked by an expert. I spoke with Palman Angelov, who's one of the leading machine learning experts in the UK, but it's still me presenting it. There are going to be mistakes. There are going to be things I get wrong. Please accept my apology for that, but this is a learning experience for all of us. If any of you notice mistakes, please do at an appropriate time let me know, because I'm here to learn just as much as you guys are. So, convolutional neural networks. What the heck can you do with this information? Well, lots of things really. As usual, I've just noticed the cropping is a bit weird on this, but whatever. There's quite a few things you can do with it. As usual, the salaries up there, they're taken from Glassdoor, so take it with a very large rock of salt. As for things you can do, CNNs are predominantly used for image recognition and image processing. There are other applications to it, but these are just some of the things that you can do with them. So who was here last week? Don't be scared. or should you be? So of those who put their hands up, what do you remember? If anything. It's completely fine if the answer is nothing. Say that again, sorry? Yeah, we used Google Colab.
How's credit card fraud and for them not to notice?
I didn't teach them that bit. That's for my other session later. I mean, yes, you're right. Sure, whatever. Yeah. Sorry, you put your hands up as well? That's correct, yeah. So I'll be repeating some of those as well in a moment because I understand we have a lot more people this week than we did last week. So one of the things we mentioned is what machine learning actually is. So there is more to machine learning than just ChatGPT. I know you all know what that is. It's not the same thing. In fact, artificial intelligence is basically when we try to make a computer replicate a human in some way or form. So with ChatGPT, it's through natural languages. It tries to mimic the human, basically. Machine learning, that's not our goal. Our goal isn't to make something quasi-sentient. Our goal with that is to use data and statistics to try to understand something, to try to get insight on the problem and maybe make predictions with them. Deep learning is a subset of machine learning whereby we use neural networks and just multiple layers of them. So not all the machine learning is deep learning, but not all deep learning is machine learning and all those good things. As a very, very brief in the nutshell of last week's session, there's several types of machine learning. The ones that are most common is supervised, unsupervised, and reinforcement. Supervised is basically where we give the answer to the machine already in our testing data, and the machine has to, or our model, sorry, has to try to figure out what weights it has to do in order to get that same result. So you'll see up here, we've got a neuron. All neural networks are made up of neurons just chucked together and speaking to one another. And we have our features or our data going into each neuron. And then there's a bias applies. Basically, what bias should that be in order to get the result we want? We also split our data between training and testing. So like I said, with supervised, which is what we will be doing tonight as well, we're giving the machine the answer, but only for some of our data. We need to make sure that the model actually works before we test it on real scenarios or real people. So we save some of our data for training our model, some of our data for testing the model and seeing how good it actually is before we deploy it into something else. Google Colab was mentioned. We'll use that again in a moment. There's also TensorFlow here. TensorFlow is a Python library, which is basically very good for machine learning. For those of you who don't know what Python is, oh boy, you're in for a treat tonight. Python is basically a programming language which assists in, well, making your computer do things. So this is what a typical neural network looks like. You could probably recognize most of you what this is. This is just a standard Excel sheet or a CSV file of some sort. We've got columns, we've got rows, it's got all the information, we've got the outputs. So these are the answers that we're giving to the machine. If we tell it we've got someone that's age 27, this is their height, this is their weight, and the answer is 1. We'll feed that into the network, and we'll tell it the answer should be 1. And the network will do some funky maths, which I'm not going to scare you off about right now. Just understand that it does some maths, it does something called backpropagation to teach itself that that answer should have been 1. What does it need to change about these weights to make sure its answer is 1? And how do I make sure that this one's also 0, and this one's 1, and this one's 1, so on and so forth. In other words, how does it learn what the answer should be? Now, we'll be using convolutional neural networks, just something to quickly mention. So a support vector machine, something that I learned in 403 last week when I snuck in, that's the OG version of a neural network. Essentially, what a support vector machine is it takes your data and it tries to find the line of most division. This is often called the hyperplane. oh, it is called the hyperplane, sorry. It looks at the data of one thing, so maybe a 1, another thing, maybe a 0. Whereabouts plotted on a graph is the best degree of separation. And that works for a lot of things. It worked for a lot of things for quite a while. We then upgraded to using artificial neural networks. These are based on a model of a brain, of a biological brain. Like I said, we use lots of neurons. They all speak to each other to try to produce an output. This is good for linear regression and NLP. Convolutional neural networks were an advancement of that, mainly in the field of image processing. And much like a biological brain, these are modeled after a biological visual cortex. So it's very, very good at image processing, because that's essentially what it's for. Further into image processing, now most people, most industries use vision transformers. I don't understand this section quite so much, but Alman told me that it's similar to CNNs, but doesn't use neurons. Instead, it uses transformers to pick out different features of images and find out which bits are important. It sounds like a fascinating field, which I'm nowhere near qualified enough to speak about, but I highly recommend anyone who is interested in image processing to explore these options further. Like I said, though, we're just going to be using convolutional neural networks, but that obviously begs the question, what the heck is convolution? Does anybody know already what it is? And those same people with your hands up, could you explain it so that anybody could understand? Give it a shot.
So, in a normal neural network, it's like feed forward. So you have layers of neurons, and you have weights connecting every neuron to every other neuron in adjacent layers. But then convolutional neural networks change it up a bit and have different structures. So they, you imagine like an input image being expressed as like big vectors, activations. You might have neurons which just connect to 9 of the neurons in the previous layer, and they'll be picking up, basically just looking at a 3x3 grid of pixels, and they'll pick up a feature, and that'll help better understand the image.
Very good, thank you. What are you doing in CompSoc Basic? You should be teaching this stuff. Thank you so much. That's more or less right, yeah. So, just to give a quick overview for those who aren't computer scientists, when we have an image, let's take the CompSoc duck, for example, it's not just like that. It's made up of pixels. So if we zoom in, it looks ugly, to say the least, because you can see all the pixels. If we zoom in a bit further, it looks even more ugly. At this point, you should make out that it's binary within the CompSoc duck. So if you can if any of you work out what the hidden message is, let me know, and you will win nothing. But it would be a fun exercise for you to do anyway. So we're zoomed in. I'm not going to go any further in. You get the idea. We've got pixels, and they each have different values. These are RGB values, or red, green, and blue values. This is basically how much light of each color is required to produce said color. So for example, we've got 0, 0, 0. That means 0 red, 0 green, 0 blue. It's black. You're not going to see anything. If we go back, look, we got some black there. We go forward. It's going to be black because there's no light going through. Whereas here, we've got more red light than we have the others, so it makes sense that when we go back, we can see that it is a red section. Cool. That's a lot to look at, so I'm just going to simplify it a little bit, combine all the numbers together, and then we're going to call this an input map. So our image, that's the input. All those numbers, they're the pixels that make it up. They make up the coloring of said picture. We've got a filter. This is often called a kernel as well. And the job of that filter is to basically go over each pixel, do some maths. In this case, it's just some simple addition or subtraction, and then produce an output map. So off it goes. It looks at the first pixel. It does the maths, and we expect our output map first bit to be 0. We then move along, we do the same thing for the next pixel, so on and so forth until we have an entire output map. This is our feature vector. So these is what we'll be feeding into the neural network in order for it to try to make some information out of it, try to make sense of it. Are we all clear so far? I'm trying to have it as explainable as possible, but I understand it's a very heavy topic if you've never seen it before. So, in a nutshell, you get your image, you break it down to the pixel, you do some funny maths to it, and then you feed it into a neural network. The network then tries to make sense of the data. Okay, this is where we get a little bit serious. This is where things take a little bit of a turn. I'm just going to read straight from this. These are from the NHS Diagnostics Imaging Datasets Annual Statistics, which released in December 2022. 44 million imaging tests were reported in England in the year to March 2022, compared to 34.9 million in the previous years, an increase of 26%. Plain radiology, or X-rays, was most common with 21.8 million procedures, up 30% from 2020 to 2021. I was informed just before this session started that that figure is now out of date because the most recent report has come out. Mondo, how much has it gone up now? 10%. Gone up 10%. That's quite the increase. From the RCR Clinical Radiology Workforce Conference, again, this is the 2022 edition. I'm not sure if they've also updated it since then. The UK has a 29% shortfall of clinical radiologists, which will rise to 40% in 5 years without action. Only 24% of clinical directors believe they have sufficient radiologists to deliver safe and effective patient care. 100% of clinical directors are concerned about their staff morale and burnout in their department. 76% of consultants, or WTEs, who left in 2022 were under the age of 60. 99% of departments were unable to manage their reporting demand without incurring additional costs. And therefore, myself personally, I have had my X-rays lost twice. One was not for a serious condition, the other one was. I was not happy about that, and I don't think they are either. These are scary, scary things to read, and I'm sorry, radiologists, to be putting you on the spot like that. It's really rough. Yeah. Disney has more robots than the UK has radiologists. If this, Mondo, perhaps you can fact check me on this. The UK, according to the RCR Clinical Radiology Workforce Census, has 4,745 radiologists as of 2022. Disney has around 6,000 animatronics. Remember that next time you watch Five Nights at Freddy's. We are all screwed. Horrifying stuff. Let's get to work. So if you've got your laptops, I encourage you to play along as well. Please visit the link that's on the screen now. Our task as machine learning engineers / doctors is to make things easier for our medical colleagues. They are having a very rough time, and you know that. We will be using a data set of approximately 110,000 chest X-rays to assist doctors and radiologists in speeding up patient diagnostics while easing the pressure radiologists face every day. So I'll give you a few moments to visit that link. It's going to open up to Google Colab. It's going to have quite a bit of boilerplate, boilerplate. You've got half the code already there. Unlike last week, we're not doing stuff from the ground up. We've got a lot of things already prepared, and we're just going to fill in the most important sections. So I'll give you about 2 minutes to go do that. So you'll know you're on the correct thing when you see all this stuff appearing right here. Hello. Yes, absolutely. So the link is bits.ly/CSS week 8. It is case sensitive. So if you don't put in the cases in the correct way, uppercase, lowercase, I'm not sure if it will send you anywhere, probably nowhere. So I'll give you another 30 seconds or so to pull that up, and we shall get started. Cool. We'll proceed. So what you might want to do as well is you want to go to runtime. No, you don't. You want to go to, yeah, you want to go to runtime, change runtime type, and you want to make sure you're connected to a T4 GPU. If you want to spend money, you can go for the more advanced GPUs, but I'm assuming you will want to do the free one, so just connect to a T4 GPU for now. This is important because, as I just kind of hinted to, it will connect you to a GPU, or a general processing unit. So we'll get to those bits in a bit. I'll tell you why it's important later on. Just make sure you're connected to one, because it will speed things up tremendously. So for those of you who haven't used Google Colab before, it's a Jupyter Notebook style text editor, which lets you either write your own notes or use your own Python or C++ code in an arbitrary sense. To use it, we're just going to click on this first area of code. We're going to do Control-Enter on the correct machine. Give it a second. So what it's doing is it's importing all the libraries we're going to need. It's importing the data that we'll be using, and it's putting it into local files which will be used on our Google Colab just for this session. The second we close our browser, these files are removed. So if you want to use this data later on, you'll want to download it before exiting out. Also, I should mention that this is not my code. We are using the code from Dr. Jason Adelberg. I do recommend checking out his work. He is a radiologist and also a software developer. Check out his stuff when you have time. So we've imported all our data. If we click over to here, we can see we've now got some files appearing. We didn't put them there. It must be the ones we downloaded. We open up medical AI. We can see labels.csv. We can see images. If we open the images file, we'll see a metric butt ton of images. If I download one of those real quick, we can see a lovely X-ray right here. Just out of curiosity, Mondo, what's happening with this patient? Sorry to put you on the spot like that. You think it's normal? All right, we'll keep that in mind and we'll check it later on. I'm not that evil, okay? So these are all of our pictures. Our pictures are loaded up. The first thing we need to do is we need to add what we are looking for and where to find it. So feel free to code along as well. We are going to do finding equals, and we are going to look for pneumothorax, which is what we've been learning about earlier. Pneumothorax. Do you need me to zoom in, by the way? Yeah. Is that better? Okay, you can all see it clearly? Perfect. So we're doing pneumothorax, finding equals finding dot capitalize. So what we're doing here is we're just making sure everything's capitalized so it can read from the CSV file, okay. Our data frame is going to be pandas dot read CSV, and we're going to give it the link to our CSV, which is content, medical AI / labels.cs, if I can even spell. That should be correct. So if we do Control-Enter, we'll find out that I spelled something wrong. You will have to get used to this. Finding dot cap. Is that happy now? It's happy now. Cool. So what we've done is we've now opened up the CSV. CSV, if you don't know what it is, it's basically like a spreadsheet full of data. In this instance, the data is the readings of each of those images, whether it has something or it doesn't. So we've loaded that in. What we're doing next, or what's happening next within the code, is we're finding out how many positives there are, how many negatives there are. Let's find out how many positives of pneumothorax we've got in this data sheet. 98. That's not a whole lot. I thought we just submitted 110,000 x-rays. Yeah, well, life is hard sometimes, and our data set just doesn't have that many pneumothorax cases, but that's okay. If any of you decide to work in the medical field, you'll be exposed to a lot more. But we'll do this for now. We've got 98 cases. What do we need to do next? If you remember what I mentioned earlier, we need to split our data. We want 80% to be for training our model, and we want 20% to be for testing. So we're going to do train underscore ratio, ration, what? Equals 0.8. Test underscore ratio equals 0.2. We're going to do train underscore n equals setting an integer to the number of, to the number in the train ratio. Let me just copy that over. Cool. Test underscore n equals an integer of n times test ratio. Did I even spell that right? Ah, yeah, that's right. Thank you so much. And what we're going to do, we're going to print to the screen. I'm going to print train underscore n, training cases, just copy and paste that, no one will notice, and we want test n, testing positive cases. So what we're expecting here is to see just how many of those 98 cases are being split into our training data, how many is put into our testing data. So we'll do Control Enter. Something's gone wrong. What did I do? Oh, because I put these in brackets. These used to be in curly brackets, curly braces, sorry. That. There we go. So in our training data, the data we're using to make our model work, we've got 78 cases. And then in our testing data, to make sure our model actually worked, we have 19. Cool. We're going to just hit the next one, which labels our data. We're also just going to hit Control Enter on the next section. What this is doing is basically making files to save the results. So if we open up this, images. Here we go. So this is where our images are going to be located, the ones that we've just made. So we've got our testing images, we've got our training images. Cool. Next thing we need to do, we're just going to display some of the blah, blah, blah. Yes, I know. Next thing we're going to do is display some of the x-rays. We've really done the hard work for you. Basically, we're loading some of the images into the current memory, and then we're going to display them. To do that, we're just going to get rid of these lovely hashtags here. This isn't Twitter after all. And we're going to do plt.show. And we're going to do the same down here. So now if you run that, give it a few moments, we can see that, oh, why does it look like that? That's odd. It works anyway though. So these are images which, according to our data set, so we haven't done any machine learning yet, according to our data set, these 6 images contain pneumothorax, whereas these don't. Maybe they contain something else, but for what we're concerned about right now, they don't contain pneumothorax, which is cool. Next, we need to train the model. The first thing, well, train it. We can't train it. We haven't made it yet. So we're going to design and compile our neural network, which I'm sure the computer scientists, this is the bit you've all been looking forward to. So to do that, we're going to get our layer X. We're going to do layers dot flatten. And what this does is it makes the output layer one-dimensional. We can do last output. Okay. Once it's like that, we want to do layers dot dense. There will be a day where I'm able to remember all of this or just know how to do it off the top of my head, but that day is not today. We want activation to be ReLU. So this is an activation function to make sure that our neuron actually turns on and is actually contributing to the model. We want another one, layers dot dropout to be 0.2 to X, and we want X equals layers dot dense 1. We want the activation to equal, if I can read on there, sigmoid. So sigmoid is good for binary classification. It's good for if it's one thing or the other. So like I said, at the moment, we're only interested if the patient has pneumothorax or not. Oh, God, yeah, you're right. Yep, thank you so much. Activation, we want that to be sigmoid, won't it? Sigmoid, I think I spelled that one right. And we want that to be applied to X. Our model will equal model pre-trained model dot input, and it's going to be with X model dot compile. We want our loss function to be binary, oops, no capital, binary cross entropy. I think that's spelled correct. Our optimizer to equal to be Adam. We want the metrics to be accuracy. What did I put on there? There we go. And then we're going to do print done compiling model. What is it not like? Oh yeah, I need to put it in quotation marks. Okay, so there was a lot of me not talking there. What? Sorry? That is, oh yeah. Droop out, lovely. Hey, it likes it now. Okay, so that was a lot of me not talking and just typing. I'm not that good at typing and talking at the same time. Hopefully I'll get better with time. Anyway, what's going on? So we're building our neural network. We're doing the layers. We're saying how many nodes we want. Dropout. What does this mean? So if we go back to here, dropout, oh, yeah?
Randomly set a certain amount of the activations of the neurons to 0 during training to prevent overfitting?
Essentially, yeah. So as you can see up on the screen now, what we've done is we've temporarily removed, or just set to 0, some of the neurons so they don't work. We've essentially given our fake brain damage. But this is a good thing, because what we're doing here is we're forcing the other neurons to work for it. We're trying to get them to really put in the effort to get a response from them. This is good for avoiding overfitting. So overfitting is where learning no longer takes place. You're just remembering the answers from previously. So it's really good at looking your testing data, your training data, but it's terrible looking at your testing data. Also, something else, real quick. Anybody can answer this. What's this? Are you sure? They are indeed carrots. Yes, of course. Well done. Okay, so these are carrots. We all know that. We all understand that. But here's another question. What's this? Who said that? Are you sure?
I think it's regular carrots.
You think it's regular carrots?
We do not know the original orientation of the carrots. The previous image might have been rotated.
I'm hearing a lot of carrots. But why? I mean, we just saw these are carrots, and they're very wide, and they got green on the left-hand side, and they've got like a bit of white at the top. This, the white is on the, I guess you could call it the right-hand side. There isn't really a left. They're rather drooping down. They look different. Of course, we've learned how to recognize, yes, this is the same thing, but for a computer model, you've just shown it two completely separate things there.
You still say the relative distances between the two is the same, like where they are in relation to each other in the image?
Clarify?
As in, like, the green will always be opposite to the sort of pointing of the carrot. So it can recognize that.
That's a very human thing. You've recognized that, yeah, the green is always on this bit of it, so wherever we position it, it's going to be like that.
What I mean is, like, if you notice that the distance from like, the end of the image is, if the computer does that stuff, like, can you have it check relativity as well?
You could, yeah. Unless we tell it to, it's not going to do that. Unless we tell it to, it's not going to do that. Yeah?
So if you wanted to train your network to recognize objects, and you were worried your training data wasn't really diverse, perhaps you could incorporate lots of variance in the training data. So if it had included in the training data upside down carrots, it would recognize it's still a carrot, like we do with our life experience. We learn it's still a carrot.
What you're talking about there, and the way how we implement your response, is through a process called data augmentation. So we haven't made up data. We've still got the same amount of data, but according to the computer, we've shown it a new image, a new valid, real answer that we can give. And through that, we can extend the amount of data we have. So going over to our neural network again, sure, we've gotten rid of some of the neurons through dropout, but the next thing we can do is apply data augmentation to it. So let's do that very quickly. We're going to say that train underscore data gen is equal to image data generator. And what we're going to do to it, we're going to rescale 1./255. We're going to do rotation underscore range. We'll set that to 40. I know it's not liking me for one reason or another. Oh yeah, I need to put that there. That needs to be equal to. You should like that. Why don't you like it? Oh, I should like that. It's curly brackets. We'll just quietly ignore the problem and hopefully it will go away. Rescale. Oh yeah, it's not supposed to be curly bracket. It's the flat, it's the that one. So this is for rescaling it to some degree, like just changing around the size of it a little bit. Not too much, but just enough to look different. We're going to rotate it. Oh wait, no, here we go. Width underscore shift underscore range. So we're going to shift it over on the width side by a little bit. And we'll do the same here. Height underscore shift underscore range equals 0.2. And we're going to do horizontal flip equals false. Why would we do that? Med students, you're still here, right? I haven't bored you to death, I hope. Why would we maybe not horizontally flip an X-ray image for our computer model?
Because they're not, X-rays are not symmetrical. So if they're coming back, there's a case of like, there are some records that make the digits look into on the wrong side, and also being able to identify what side the problems are.
Mm-hmm. Yeah, no, absolutely. But by including flipping around and stuff, it's just not typical practice. And doing stuff that's out of the ordinary would just confuse the model. So we'll avoid doing anything too out of the ordinary. Thank you for that, by the way. Let's see if that works. It doesn't like that one because I haven't put a comma at the end. Or there. And now it likes that. Cool. So if we scroll back up real quick, we'll see that we had 79 training cases and 19 testing cases. Now, because of our data augmentation, we have 156 in training and 40 in testing. So we've essentially doubled our amount of data while still using the same data. Very cool. Now we need to run the model. I haven't removed this bit because I feel I've already been using way more time than I was expecting to. So just hit Control Enter and pray that you've already connected yourself to a GPU. Otherwise it will take a very long time, approximately 8 to 10 hours, because that's how long it took me while I was testing this out the first time and then discovered that you can use GPUs. While it's doing that, epoch, by the way, is just how many times it's running through our data set, for those who don't know. So it's got 1 of 10, it's going to run through our entire data set of pneumothorax cases and test it against the testing data 10 times. It shouldn't take too long. While it's doing that, let me just quickly show. Oh yeah, this is why we're using a GPU instead of the CPU. It's got more cores, and the cores do funky maths with floating point numbers or numbers with a decimal point in them somewhere. a CPU or central processing unit, they have like 4 to 16 of these, whereas a GPU could have several thousand of them. So unless you want your model to take a long time, connect yourself to a GPU. So while that's busy churning away its model, let's figure out how we can actually evaluate whether our model is any good. We have several methods. We've got accuracy, precision, recall, F1 score, and the med students among us will be interested in the sensitivity and the specificity, and we'll all be interested in the ROC curve. Sensitivity is how like, yeah, I should have kept my notes up on here. So sensitivity is true positives over true positives plus false negatives. High sensitivity may predict more false positives, but it will be less prone to false negatives. If any of you have done machine learning already and you know what recall is, it's the same thing. It's just called something else in the med field. Specificity, how good it is to like doing this bit. True negatives over true negatives plus false positives. Higher specificity typically has lower false positives rate, which is what we want. Like here, we don't want too many false negatives because that's terrible. You don't want to be misdiagnosing someone. You don't need to be a med student to understand that's very, very bad. I think false positives is probably less bad, although that's still also very bad because then you can give them the wrong medicine or the wrong treatment for something they don't even have. So ideally you want both of these to be as high as possible so you're not misdiagnosing the wrong people. Finally, the ROC, or the area under the curve thing. Essentially this looks at how good your model is at discriminating. I know it feels weird to say, but in this case, discrimination is a fantastic thing. The closer you are to 1, the better your model is in distinguishing what is what. So let's find out how we did. So it's gone through all of our models. It was very, very quick, 24, 9 out of, like what, not even a minute of training. That's not too bad. Let's see how well it did in that time. In terms of accuracy and how well it was able to make these predictions, with the testing data, it done fairly okay. We can see it's averaging around about 75% accuracy, and the loss, so the difference between what its prediction was and the actual output, very close to 0. That for an hour of work and a minute of training, that's not bad. If we now run through the next modes of evaluation, blah, blah, blah. I'm going to skip that bit. Actually, wait, no, is that bit not long? Yeah, we'll skip that bit for now. No, I do need to include it. I should not have done that then. Okay, so we're going to have a look at some of the x-rays and see how well it did with them. Import random, n equals random dot randint. So this is going to select a random image from our outputs, from our data set, data frame -1, apart from anything beyond it. And it's going to show the data frame row df.iloc n. What's it not liking now? And then we're going to do df file. We want to have the name of the file. We want to have the label that it's been given within the data set. We want to have the guess that was made by our model, and we also want how confident it was. So confidence, what's it not liking? Show df row df dot. Okay. Okay, so we can see for this one, according to our data set, this person does not have pneumothorax. And our model guessed they don't have pneumothorax. It had a pretty low confidence score that it was of 0.0004. It's pretty certain that it's not there, and according to the data set, it doesn't have it either. If we run it again, it will show us a different one. In this case, it was pretty confident that the guess was positive. The confidence score was 0.96. You can think of that, it's 96% certain that this contains pneumothorax, and according to the data set that we're using, it does indeed have pneumothorax. Let's see if this bit wants to work now. That seems to be, why is it not liking it? Bins, name bin was not defined. We'll not worry about that. Does this one work though? Here we go. So we can see our ROC curve was 0.85, so it was pretty decent at discriminating between X-ray images that have pneumothorax and those that don't. Will this exact model ever be used in a medical field? I hope not, because it hasn't taken, I mean, sure, yeah, we're going to be running over tonight. Sorry about that, guys. But like, it hasn't taken us all that long to make that. And it didn't take much time to train it either. With a lot more time, if you are interested, you could make much better models for med cases where it can be much more sophisticated and much more accurate in its predictions. Yeah?
So, if a data scientist builds a model, tries to get the best structure, to recognize the pattern, to get the lowest, highest accuracy. But accuracy in real life and how it's kind of the sum of inaccuracies in the training data, the biases in that, and how well the model learned it. Who makes the training data? Who cleans that and makes it most accurate? Is that a data analyst?
Probably data analysts, yeah. Either data analysts or the interns. Sorry about that.
I did hear about a famous case related to radiology where the network learned if a ruler was in the image, it was probably a tumor, because the doctors who were doing the training data had put rulers in.
Yeah.
And then it was terrible in real life.
Yeah, that was a thing. So just in case anyone didn't hear, there was a case where there was a machine learning model used. I'm not sure if it was X-rays or MRIs, whatever. It was some scan that was done to detect tumors and how bad they were. Problem is, they tried measuring each tumor, and they include the ruler in the images. So the model realized that if there's a ruler in the picture, oh, this person has a tumor. Of course, when you're trying to discover if someone has a tumor, they don't permanently have a ruler already there. At least not usually. So the model was useless because all of the real data going into it didn't have a ruler there. So you need to be sure that if this is something that you're interested in, if you do decide to go down this route, you have to make sure that your data is good. Otherwise, it's going to be terrible. It's going to be detrimental. But it is fascinating to see how with not really that much time, we've been able to do some things to really help out our friends in the medical field. Speaking of which, that's the end of me. Sorry I took so much more time than I was expecting, but I'd like to welcome now Roxana and Robbie from the Neuroscience Societies. Roxana, I believe you're the president, aren't you? And Robbie, you're the vice president, yes. So I'll leave it up to you guys now. Thank you so much. Let me make sure you guys are connected to that.
Can you just move it?
Connect.
Can everyone hear? Yeah? Okay.
So hello, I'm Roxana. I'm the president of the Lancaster NeuroSoc, and Robbie is the vice president. And we both fourth-year medical students at Lancaster.
That should be working now. If it
Alright.
turns off, just let me know.
Thank you. So what we're going to do is give a very brief overview about brain tumors and how you can read them on MRIs. It's not going to be a very exhaustive lecture on brain tumors, as it's a very complicated subject. So it's like very, very basic. So what we'll cover is the pathophysiology of brain tumors, types and classification, and then imaging. So to start with, I decided to include this slide just to give an overview of our nervous system. In specific, I wanted to highlight the fact that we're going to talk about brain tumors, but all these tumors that you can find in the brain, they also can be found in the spinal cord, as they're both part of the central nervous system. So just to be aware of that. So what is a brain tumor? So a brain tumor is basically a collection of abnormal cells, which is like mainly caused by like cells dividing like uncontrollably. And there's way more to that. So it can be caused like by genetic mutations or like by many other factors, but essentially that's all you need to know. So each type of tumor, it's based on like this replication, this regulated replication of cells, and based on the cell type that they derive from, you can have different type of tumors. So on this slide, you can see the main cell types that you can find in the brain. So you have, each one of them will have a specific function in the brain. So the ependymal cells are the ones that produce the cerebrospinal fluid. You have then astrocyte that can offer like a sort of structural support to your brain. And then you have oligodendrocyte in the brain and Schwann cells in the spinal cord, which create myelin, which basically is like a substance that covers the axons of the neurons. So then we can, based on like what type of cell they derive from and where they started growing, we can have a basic classification of brain tumors. So we have primary tumors are tumors that start in the brain and they stay in the brain. They are very uncommon, as they account only for 2% of all brain tumors. And the type is determined by the cell they arise from, as already said. The prognosis is usually, it can be influenced by various factors, so for example, age of onset. Yeah, so it can vary a lot, but generally the later is the onset, the purer is the prognosis. Then we have metastases. So this is the most common form of brain cancer, and they start from somewhere else in your body, and then they spread to your brain. There are many types of cancers that then spread to the brains, but the main ones, we've listed the main ones. So like lungs, breast, bowel, skin, and kidneys are the main ones, so then they will spread to your brain. So then on imaging, so we included these two examples. The main differentiating feature is like the multitude of these tumors in your brain. So primary brain tumors are usually singular. So as you can see on the right, whilst on the left we have included the metastases. So they're multiple tumors. How the patient will present to you if they were having like a brain tumor. These are like the symptoms they would usually present with, and headaches is like the main one. It usually presents like a very severe and persisting headache, worse in the morning, and that is worse when they lie down, but it's very specific to the presentation. And then based on where the tumor is in your brain, you will have different type of symptoms. As you may know, each lobe of the brain does some functions in our body. So for example, the frontal lobe is involved in personality, the temporal and parietal have like the language center there. So for example, if the tumor is in your frontal lobe, you may experience like personality changes and like irrational decision and stuff like that. While speech difficulties may be more characteristic of tumors are like in the parietal and the temporal lobe. So then, starting with primary tumors, they can be furtherly subdivided in all these other types, as we said, based on the type of cells, but also based on the severity, on how they grow, or if they like infiltrate, or if they just grow, pushing the various things in the brain like away. We're gonna just talk about like 2 types of brain tumors, as like there are so many as you saw. So the first one is glioblastoma, which is the most common type of brain tumor in adults. And it classifies as a grade 4 astrocytoma, meaning that it derives from astrocyte cells, the ones that we saw before. It is a malignant type of tumor, which has a very poor prognosis, usually between 1 or 2 years survival, 5-year survival rate. And as you can see from this picture, it's characterized by like an irregular border and is infiltrative, so it goes and infiltrates all the surrounding structures. It is also characterized by something called vasogenic edema, which Robbie will discuss in further detail later. But as you can see from the MRI, it's basically that white enhancement around it. Next one is meningioma, which is the second most common one. And it's typically benign, so it has a way better prognosis, and mainly because it doesn't tend to infiltrate or expand as glioblastoma do, but it is a very like confined and regular kind of tumor. And based on where it is located, it is more accessible surgically, so it's easier to take out during surgeries. So they compress rather than invade, so that's what I was trying to explain before. And yeah, it can be surgically resected. So sometimes it tends to attach to these linings of the brain called meninges. So they're these basically sheets covering the brain. And as you can see in this MRI, sometimes they form this sort of tail called meningeal tail. So I've included a number of cases. The first one is a 54 years old woman presented with slow thinking and a mild right hemiparesis, which means basically not being able to move the right side of her body. That's what we see on MRI. So this is a non-contrast MRI. We add contrast, and that's what you see. Any guesses on what type of brain tumor it might be? Well done, Robbie. Do you want to tell us why? Yeah. And you can also see that vasogenic edema that I was emphasizing before. As you can see, it's infiltrating in the surrounding structure instead of like having a very confined margin as the meningioma was having. So yeah. Case 2 is a 57-year-old woman presented with seizure that affect the left side of her body. And we have these 3 MRIs. So we have a sagittal view, then we have the axial view, and then we have the one with contrast. I've highlighted the tumor in the 3 images. Any guesses on this one? Yeah? Do you want to tell us why? Yeah. And can you also see the other feature that I said before about meningiomas? It's fine. Anyone else? Yeah. And it's like the dural tail that attaches to the meninges. So you can kind of see it in the last one on the left a little bit, but yeah. Okay, then last case. So it's a 47-year-old woman presented with progressive spasticity of the right lower extremity associated with headaches and a depressed affect. So this is what we see. And then, so here we have highlighted the tumor. And here we have highlighted the edema around it. So I'm just going to give this to you. This is basically the glioblastoma because it has the edema, and as you can see, it's very irregular. and here are the two images put together. I decided to include that just because based on the presentation, as I told you before, this woman was presenting with repressed affect. So sometimes someone can present with like symptoms of depression, but not be having depression. Like in this case, she had a brain tumor, and it was in the frontal lobe. That's why she was experiencing those symptoms. But yeah, so yeah, that's just. Yeah. So now it's Robbie's turn. Yeah. You do have specific cell types. As I told you before in that first diagram, there are specific cell types that are like the immune system of the brain. So in this case would be the microglia. So the brain does have a kind of like immune system, but of course it's way different to other parts of your body. So yeah, no worries. Any other questions? No? Okay. I'll let Robbie take over. Thank you for listening.
Is that working? Oh, happy days. Okay, perfect. So I'm going to talk to you a little bit about analysing the actual brain tumour itself. So Roxana's spoken about the different types of tumour, but what is important for AI and sort of deep learning is about how they can analyse that, but equally about the importance of not putting radiologists out of a job, because computers are great, but they can't do everything. So the first thing we talk about is edema. So you might have heard the word sort of bounce around a bit if you don't know what it is. It's essentially, we call it leakage of fluid into the third space. So there's the intravascular space, which is what's in your blood vessels, and then there's the intracellular space, which is in your cells, and then there's that weird sort of space between them. Now, usually you shouldn't have much in this area. It should just be empty. But you can see the foot on the right, it's got that sort of puffy area. Now, you see this in pregnancy. It can be normal. Medications cause as a side effect. But in the brain, you don't want that at all. And the brain is very sort of tight in that respect. The blood vessels are not leaky at all. Because if it happens in your foot, if it's under your skin, it's not really a problem. But if it's occurring in your brain, under your skull, you've got a big problem because you've got a very confined space and it's pushing out and it's going to eventually push your brain down, which can cause massive problems. But that's what edema is. It's just a leakage of fluid. It's just a fancy word. So vasogenic edema. This is what happens, very, very straightforward, really. If your blood vessel is broken, stuff leaks out of it, okay? It's quite straightforward. And that's caused by tumours and abscesses, okay? But tumour is what we're talking about today. And what you can see, it's not particularly clear if the mouse works. Can you see that? Yeah. So you see this sort of darker area here, and the lighter area around the outside. So if we look at the brain on a gross view, you can see that there's this stuff here called grey matter. Now, if you remember from biology at school, those doing computer science, there was the nerve, it had the cell body and then had that long bit. That's the axon, okay? Axons are called white matter, and the nerve cells, or the cell body, is the grey matter, okay? So don't overcomplicate it too much. What we can see here is that fluid is leaked out into the white matter, but not the grey matter, okay? So that's really important because it's very significant for this type of edema, which is significant to tumours. So if you see this appearance where the grey matter is preserved, but the white matter has essentially been filled in, that means you're looking at either a tumour or an abscess. Now, that difference from cytotoxic edema, which occurs following a stroke, so following infarction, you see that there's actually no preservation of the grey matter. The entire area of the brain basically has been damaged. So if a patient presents to you and they've got loss of control of their right side of the body, they can't speak, you're thinking, okay, I have no idea what's happened, how long this is. This is an acute thing, so if it's come on in, just today, or if it's been coming over months, you put them in a CT scan or an MRI and you see this pattern, you can immediately tell this is a stroke, this is not a brain tumour, and your management changes completely. So it's really important to get that right. And this just sort of explains it again. So vasogenic, it's coming out the blood vessels. Cytotoxic, the blood vessel's fine, but you've got a cellular problem. So once you've worked out you have actually got a brain tumour and you're not dealing with a stroke, you need to work out where the brain tumour is coming from, okay? Now, the key word in this one is this one here. It's called parenchyma. That just means functional tissue, okay? So within the brain, there are brain cells that make the brain work, okay? These are called neurons, or just your nerves, okay? This is the tissue that without it, the brain is not a brain. Now that differs slightly from something called a meningioma. So the meninges, which is called meningitis, the meninges is like a cling film layer over the top of your head, okay? If you take those away, your brain is still a brain, but it's just more at risk of things, but the brain is still a brain, okay? So that's called extra-axial, and that's not actually brain tissue, okay? So it's important to distinguish whether it's a cellular problem within the brain or if it's something that's just supporting the brain, because again, your management changes. So intra-axial, these are slightly more difficult to spot, but if you look down here, you can sort of see a bulge that's coming out at you at the screen. So if this is your brain and the bulge is inside the brain, it's going to propel it towards you. So it looks like it's coming out the screen at you, like you've got one of those 3D goggles on. If you compare that to an extra-axial, so this is the brain, the lesion's outside it, it's pushing on the brain, you can see that it's actually sort of squashing the tissue around it, which means that you sort of get this, well, squashing effect, basically. So that's an important pattern that if AI can recognize that, it's just compression of structures, then it's useful. And it's important because there are places that in the brain that tumors develop more commonly. So if you can recognize the pattern of the structures which are being squished, then you're able to make more diagnosis effectively. So this one's slightly difficult because I don't know if people can really see it. Can anyone see a lesion on this one? Or is it all a bit difficult? Anyone got an idea? Any medics? Come on, someone must have a go. One of you three, go on. Behind the left eye, yeah, exactly. So it's actually the right eye, technically, but behind this one here, there is a lesion, but it's quite difficult to tell, actually, if it's intra or extra-axial. It looks like there's a bit of squishing, but it's not really easy. But if we do a coronal view, it's much more obviously now. You can see a lesion here, and as Roxana mentioned earlier, you can see the sort of the tailing of a meningioma there. And if you do it with contrast, you can see it even more clearly. So this is an extra-axial. It's got that nice gleam on the outside, which is called a CSF cleft sign as well. Now, these are called intraventricular, so there are the fluid-filled spaces within the brain as well. Much more barn door. You can't really miss those as a radiologist. So the next thing, you've worked out the tumor. You've worked out where it is. Now you need to work out how dangerous it is. Is this a malignant, or is this actually just quite benign? So grading, you're basically trying to work out how cellular it is. If it's really highly cellular, then it means it's proliferating quickly. You probably need to get that out. If it's just quite small, it's very benign, you've got an 80-year-old woman in front of you, you can think, actually, there's probably something else that might kill her before this does, and actually, if this isn't a problem, we might not be able to, because you don't want to have to do invasive brain surgery if you don't have to. So you're also looking at these other things like perfusion and hemorrhages. So this is an example of a low-grade tumor. So on the left, you can see there's not a lot of enhancement. When you've given contrast, the tumor hasn't taken up much of that contrast. It's not very white, and that's a reassuring sign because it means that there isn't that much blood flow to the tumor, which means it can't be growing that quickly, which means actually not so much a problem. And then the hemorrhage scan shows the same thing. Really big tumors will bleed into themselves because they're really vascular and they're just growing. So actually, if they're not bleeding into themselves, it's probably a sign that there isn't that much blood flow to it. And this scan shows it, again, really nicely where the mouse is. There's not a lot of blood flow going to that. So actually, that's a reassuring sign that it's not growing. And actually, it probably won't metastasize. So this is a sign of a grade 2 astrocytoma, okay? Now, this is a much more concerning scan. So we can see there's this high ring of contrast, which means the cells are taking up that contrast really quickly, right? And you've also got in the middle this necrotic center. Now, a necrotic center actually means that the tumor is killing itself. Now, you think, okay, that's all right, the cancer is going to take care of itself. The problem is that because the tumor is growing so quickly, the tumor cannot basically feed itself effectively. So the center of it is dying, but the outside is getting bigger and bigger and bigger, pushing on more structures, causing more obstructive issues, which is basically a much worse sign. It's going to metastasize and move quicker. This sign shows these little specks here. That's bits of blood that are basically leaking into the tumor, another really bad sign. And we can clearly see a really enhanced ring of blood flow going to that tumor as well. So I don't really fancy their chances. This is calcification. Bone is calcified. This is a calcified tumor. Again, not very difficult to miss, but not a good sign either. And the other thing is solitary versus multiple lesions. So if it's multiple, it's probably come from somewhere else. So breast, bowel, lungs, skin, waist, sun cream, melanomas, kidney cancers as well. And if it's single, metastasis or primary tumour. And HIV is often a really big causative factor for anyone that has a primary brain tumour or lymphoma. Anyone that will have a brain tumour that's come on its own will basically have a test to see if they have HIV. So this is a quick summary. You need to work out, is it a tumour? Where is it? What's the risk? And how many are there? And has it come from somewhere else? This is a feedback form. If people would be able to fill this in, it would be awesome, just so we know what was good, what wasn't so good. But thank you very much for listening. Thanks.
Hello again. Oh, there we go. Yeah, that's on. Hello again. Thank you so much, guys. I'm going to be very, very quick with mine. I do recognize the time. I know we said it was going to be a 90-minute special. It's looking like it's going to be a bit longer than that, but that's okay. We'll try to make it as quick as possible. Oh, let's not do that yet. Spoiler alert. So if we quickly run down, all I want to do with this is demonstrate somebody's work right here. Haha, I can't even do that. Okay, let's do. All right, looks like I won't be. Looks like I will be. That's good. Okay, so don't worry, this won't be too long. All I want to do is show you this guy's work. What this guy's done, it's not even that long, honestly, compared to what we were just looking at with the previous model we were using. You don't have to be a computer scientist to realize there's not a whole lot of code going on here, and yet this guy was able to make a convolutional neural network for his own testing out, I guess, for playing around for brain tumors. You can see he's got his data set here, where he's got brains that don't have a tumor, brains that do have a tumor, and you should be able to recognize from what we said earlier, he's importing his data, he's changing around the size to make sure they're all okay, showing where they are. He's splitting the data, he's doing an 80-20 there again. He's adding the different layers to his network. He's fitting it, which means he's getting it to actually run. He's plotting his results out, and he's making sure that he's getting a high accuracy or a high correctness with it. This is someone who, well, they're probably a student like us, or someone who probably put a lot of effort into it, but you can see it's not all that big. You can see that with a bit more time, you could make something more sophisticated, more accurate, higher sensitivity, higher specificity. You could do some incredible things with machine learning to really help our friends out in the medical field. It is the most important field out there because it's about saving and improving lives. So if there's any way we can help them out, it's fantastic. I guess out of all of you, how many of you feel inspired and, yeah, let's become a health scientist and machine learning for the NHS? I don't know. Perhaps some of you, perhaps all of you, perhaps none of you. I don't know. I'd like to think that some of you would take note of some of the things that have been said today, both from myself and from the others. I guess the real question is, what could you do with machine learning? At least with the CompSoc people, this is the second week we've spoken about it. We'll briefly touch on it next week and the week after, ever so briefly, but machine learning is a fascinating field. It's not for everyone. I'll get that out of the way now. There's a lot of you that will look at this and think that's what's completely boring, I never want to touch it again. Respect. you now know one thing you don't want to do. But for those who did look at it and did think, actually, that's a really important bit, that's a really powerful tool. I could use that to do X, Y, Z. I could use that to help Mondo or Roxana or Robbie or anyone else in the health industry, or you could use it in other methods. I called it intentionally today as image recognition because it doesn't just have to be X-rays. It can be for your website to make sure that there's no dodgy stuff going on there. It could be for a self-driving car. It could be for a multitude of different things. How will you use machine learning? That's completely up to you. And I encourage you all, if you are interested in it, to figure it out in your own time. Once again, I would like to thank every single person who helped out in tonight, especially the Radiology Society and the Neuroscience Society. Can we just give them another round of applause real quick? Thank you so much. I would also like to give a special thank you to Roxana. Thank you for coming in on your birthday. From everyone at CompSoc, happy birthday. Thank you. Thank you also to, yes, thank you. She did tell me not to do that, but I am terrible at listening sometimes. I would like to give a special thank you also to MedTech for helping out tonight, to FemTech also for promoting this event and for being here. Thank you so much. Thank you all of you for being here, especially in this later hour. And also to Google, who have provided the funds we have for the refreshments. Speaking of refreshments, you will find them on the table outside. Hopefully you've got something you guys will like. Once you do have your refreshments, however, you are not permitted to come back into this room, just because there was a whole fiasco about that with booking. Once you've got your stuff, you can mingle. Please do mingle, make friends that you otherwise wouldn't have. Speak with each other out there, have some good food, have some good times. One last thing, if you are interested in some of the things you saw tonight, if you're interested in how technology can be incorporated into the medical field, I encourage you to go and check out RadSoc Society tomorrow evening, happening in Bowland North Seminar Room 2. I believe what they're doing with that, they're going to be having obviously a meet and greet and playing some VR games along with that. For anyone interested, I've mainly been telling CompSoc at the moment, but this is a competition for all individuals who are a current student at Lancaster University. We do have a competition going on at the moment of who can make the best face recognition nerve turret. You can have teams of up to 4 people. The prizes can't be announced just yet because they haven't been confirmed with us. We are still talking to the relative stakeholders. All I can say is if this is the prize in question, if we do get the prize we're looking at, you want it. You
Okay, your budget's a bit different than
you would, every single one of you would want this prize. If we don't end up getting it, then, well, sorry, it will still be a cool prize. But the one we're trying to get, we're still waiting to hear back from people, you want it. And that's all I can say. Thank you very much. Good luck with all of your things. Please have some food and good night.